October is Breast Cancer Awareness Month, and Carolee McGrath sat down with Dr. Grace Makari-Judson, the chair of Baystate Health Breast Network, to learn more on the treatments available and how you can reduce your own risk.
It's really important to try to identify people that carry a hereditary susceptibility to breast cancer and potentially other cancers as well, because we do have strategies that we can watch people more closely and potentially prevent a future breast cancer or other cancers. We have a number of tests that are available. We know a lot more now than we did 20 years ago, and so we want to identify the right people to test and do the right test on those individuals so that we can best advise them.
So if you have a family history, you would be somebody that would be a candidate for this testing?
It all starts with the primary care provider, and it's important for them to take a good family history and personal history. If someone has a personal history of cancer as well, that's important. And then they can refer the appropriate individuals. We do have guidelines, and national, a number of the national guideline producing agencies do have guidelines of who should be considered for referral. Once they're referred to a cancer genetics specialist, then they could be counseled and considered for testing. Some of the things that we ask people is, what would you do with the information if you were found to identify, if you were identified to carry a genetic susceptibility? What would you do if you're not? And, you know, one of the important things is many people are tested and they're negative. In fact, most people that are tested are negative, but they may still be at risk of cancer. A negative test doesn't mean that someone would never get cancer.
So what do you do if you find out that, yes, you are at that higher risk?
There are a number of different genes that we can test for. Some of them are associated with a slightly higher risk than the average person. Some of them are associated with a very high risks. For example, BRCA1 or BRCA2, we can see lifetime risks of 60 to 70%, which compares with the average risk woman who would be only 12%. But some of the other genes that we identify may be just slightly higher, maybe a 20 to 40%. And so based on a person's individual and family history and the gene, we may be able to counsel them in terms of what steps they can take to be watched more closely and what steps can they take to potentially prevent cancer.
And that certainly will come up in the conversation of when to get a mammogram, correct? That would be one of the steps that you would counsel them in?
In women that are high genetic risk, we may do breast MRI in addition to mammography, and we may start as early as age 25. But in women that have a family history but don't have a hereditary susceptibility, it may be very reasonable for those women to start at age 40.
So talk a little bit about the actual age for just women in general to get a mammogram. I know that there's been some controversy surrounding it, and some recommend 40. I've read something else from the American Cancer Society, 45, and then another one was 50. So where do women in general, you know, start?
The first place to start is with a risk assessment. So understanding a woman's personal risk based on her own health and her family history is the first step. And then if someone is deemed to be average risk based on their personal and family history, then it's reasonable to start anywhere between age 40 and age 50, but no later than age 50.
Okay. When we think about Breast Cancer Awareness Month, and I know you've been treating people for a long time, there's been so many advances that we've seen in the last 20 years. Is there more hope, would you say, for women facing this?
Absolutely. It really is remarkable to look at how far we've come, not only in terms of diagnosis, but especially with treatments. We can be much more specific today with targeted treatments in terms of identifying what is absolutely necessary. One of the big themes of cancer treatment now in the recent years has been trying to minimize toxic treatments and trying to really give the treatments that are most necessary. So we're looking at minimally invasive surgery, we're looking at omitting chemotherapy in people that don't need it, that can get hormonal treatments, we're looking at people that might not need radiation. We're looking at lesser types of surgery of the underarm, the axilla area. So in many areas in breast cancer, we work together as a team so we can coordinate all of the treatments and maximally increase the likelihood of being a survivor and being a survivor with minimal late effects.
Getting back to the genetic testing, you had mentioned, that some people want to know and some people might not want to know. And what would you do with that information?
Yeah.
It is kind of a heavy burden to carry, I would say, if you do know that, yes, you're higher at risk and it's been confirmed through a test.
So most women really want to know. So for example, a woman that finds out that she carries a BRCA1 or 2 mutation could make a decision to have the ovaries removed before age 40, and that would lower her risk of getting ovarian cancer by 97%. Ovarian cancer is much harder to diagnose, it's much harder to treat, it's often picked up late. But the other thing is that by removing the ovaries in a woman before menopause, we could cut the breast cancer risk by 50%. So we're doing something to reduce 2 cancer risks. And and often removing the ovaries can be a day-stay procedure that's laparoscopic, not that much in the way of toxicity. It does lead to early menopause, which needs to be dealt with. But that's an example of an intervention based on genetic test results that can really, really make a big difference.
Right. As a doctor, though, that there's going to be people who have that emotional, of course,
Yes.
we're petrified,
Yes.
to find out and to deal with that information.
And remember, a number of these women may be women that have seen their mothers die young or had seen their sisters die. And I think for them, the chance to be able to do something to reduce cancer risks is really important.
Tell us about your tissue registry research.
One of the things that we've been successful in doing is gathering tissue, leftover tissue from breast surgeries that otherwise would not be used for diagnosis, and making use of that for investigators. It's really helpful to have tissue that's also linked to clinical information. We have over 1,000 women that have agreed to participate in the breast research registry over the years. And we now also this year have started a special registry for women with metastatic breast cancer. Now the goals of these registries are, again, to be able to get information from tissue and be able to ask certain questions and get answers that may be specific for individuals as opposed to just a population. So for example, one of the things that our investigators have been able to do with the tissue cultures, instead of having a 2-dimensional tissue culture on a petri dish, for example, they're able to do these 3-dimensional, what are called organoids. And in a way, this is something that could potentially take the place of animal research because of the fact that we can look at individual variation and we can get much more information.